Workforce is another key element in the structure of oral health care and access to care. Let's look at the elements of the oral health care workforce and some of the political issues that affect it. The traditional dental model consists of the dentist, an assistant, and a dental hygienist who cleans teeth, takes x-rays, and offers general preventive services. Expanded and alternate models have entered the landscape. Some are just emerging, and some have presented a great deal of controversy. Expanded function dental hygienists and assistants have been on the scene for a while and have begun to be accepted. Community dental health coordinators and oral health preventive assistants are newer models offered by organized dentistry. Mid-level providers, however, have entered the scene relatively recently and have been met with controversy because of the scope of work that they are doing. And in addition, we have two other models, the primary care physician entering the realm of oral health care, and the oral physician, which is an expanded version of the dentist. Given retirement, an increase in the number of women in the dental workforce, and a general lack of increase in dental school graduates, the forecast for dentist manpower is that it will decrease in the next decades. While some dental schools have opened to take the place of those that closed, it is apparent that we will still need additional manpower. Another factor to take into account is that dentists tend to practice in urban areas, leaving underserved and rural areas without needed manpower. Clearly, as in primary care medicine, a diverse workforce and expansion of the scope of work is needed to meet the needs of the patients. State regulations play a huge role in who does what, and this landscape is constantly changing. In this excerpt from the Pew Center, which grades states on certain oral health benchmarks, we can see that the ability of dental hygienists to determine a child's need for dental sealants varies greatly by state. Dental sealants are plastic coatings placed on the teeth to prevent decay, a totally non-invasive procedure. In 2011, 5 states eliminated rules requiring a dental exam by a dentist prior to a hygienist applying a sealant. However, despite the growth and proven efficacy of school-based programs, 8 states in the District of Columbia still require a dentist to be present when sealants are applied in these programs. This greatly increases program costs and decreases feasibility. Maine's Board of Dental Examiners passed a rule prohibiting children who had seen a dentist in the past year from getting school-based preventive care without their dentist's approval. Clearly, the power of organized dentistry in some states has greatly affected care for the most vulnerable populations in those states. Let's take a look at the types of expanded workforce. The typical dental hygienist has a scope of practice that varies from state to state, but generally preventive services, teeth cleaning, x-rays are included in that scope of practice. Expanded function dental hygienists, where they are allowed, can provide additional services. In Massachusetts, there is a model called the public health hygienist, which is an individual who can practice in public health settings independent of a dentist with just general supervision by a dentist. Dental assistants are the individuals who usually sit next to the dentist and help them with procedures. Expanded function dental assistants also can do additional procedures and help in the workflow. Looking at the alternate dental workforce models, 2 have been embraced by organized dentistry: the community dental health coordinator and the oral preventive assistants. These are mostly assistant models who do not do any invasive treatment. Other models, particularly the mid-level providers who can perform procedures that can impact and address the need for care, have met a great deal of controversy, even though they primarily work with populations that are underserved. The advanced dental hygiene practitioner emerged primarily in Minnesota. There is a training program for these individuals, and they are committed to working in underserved areas. The dental health aid therapist, or the so-called Alaska model, also works primarily in underserved areas. But these two models have met with opposition in many states and from organized dentistry in general. Here we see a spectrum of oral health care from the simplest procedures to the most complicated, and the scope of practicabilities for each category of worker. The dentist is still the only worker who can legally do complicated restorative dental procedures. However, the ability to diagnose has been extended slightly to other workers. You can see that limited and variable and partial appears on this graph or this table primarily because the scope of work can vary from site to site. One of the most promising alternate models of dental care is the inclusion of primary medical practitioners in the care of children. This model is promoted by both the American Academy of Pediatrics and the American Academy of Pediatric Dentistry. While not always smooth sailing, it has been a promising cooperative model, decreasing the gap between oral and systemic health. Since we know that financing is a major factor in care delivery, it is encouraging to note that the reimbursement for physicians who perform oral health care procedures has grown, as seen here from 2008 to 2012. Lastly, let's look at a new horizon, the rise of the oral physician, the integration of oral and systemic health such that the dental profession can be a participant in the overall health of its patients. The oral physician is a model to train dentists to work with physicians in providing limited preventive primary care as well as screenings of chronic health conditions. A sign of the times may be that the American Dental Association recently did an analysis of the cost savings to the healthcare system by having dentists screen their patients for chronic medical conditions. In this study, they examined what would happen if dentists could screen for hypertension, cholesterol, and diabetes, particularly in a group of patients who had not seen their physician in over a year. They found that a number of new cases, early cases, could be detected and potentially save money down the line in the healthcare system. Clearly, time will tell, and dental education will play a great role in whether this expansion of the dentist's scope of work will actually occur. Some institutions, such as Harvard, are moving forward with this concept of the oral physician and actually building on their historic connection to medicine. Their new strategic plan includes a version of the oral physician. To quote Dr. Donoff, the dean at Harvard, "In general, medical education seeks to graduate an individual with an understanding of patient care, while dental education seeks to graduate a provider of care." Moving away from the idea of fee-for-service as a provider of care, a provider of procedures, and gaining a better understanding of overall health will help to bring the medical and dental fields closer together and perhaps ease some of the challenges that the dental care system has faced. I now turn this over to Dr. Reedy, who will continue the discussion.